My name's Matthew Mullarkey. I'm one of the neurosurgeons. I operate out of both Southeast Memorial Hermann as well as the Texas Medical Center. I did my training, my residency training I did at UT at the medical center, and then subsequently went on and did fellowship after my training. You treat a variety of conditions, anything neurosurgical related, but one of the more common things that we see is neck and back pain, which can be complex issues. A lot of times the workup for these problems can be a little bit challenging, but there's certain things and certain symptoms that we look for in patients when we're seeing them to see what type of management we can offer them, and that ranges from a whole host of conservative therapy, including physical therapy, pain management, and then eventually, or not eventually, but sort of the last line treatment is surgical treatment. So I wanted to talk about specifically neck pain and as well as arm pain and associated numbness. And this is a very common problem that I see. And like I said, just because you have neck pain or if you have some arm pain doesn't mean that you need surgery. I mean, there's a whole host of treatments that we can offer up front prior to considering doing surgery. I almost never offer someone surgery for neck or back pain up front. There's very rare situations where I see somebody in my clinic or in the ER and they need something done, that hospital admission or shortly after that clinic visit. A lot of times the workup is extensive, and a lot of the measures that we take are pretty extensive to make sure that, one, we give you the best shot that we can without a surgery, and two, that you'll actually benefit from a surgery if eventually you are a surgical candidate. Next slide, please. So neck pain, it's a very common condition. It affects up to 70% of adults at some point. It is a common cause of disability and reduced quality of life. And I'm sure, as some of you may know, some of this neck pain can be acute and some of it can be chronic. And typically we say chronic is longer than about 3 months. And again, there's a variety of factors that can cause this, but some patients come in, they have neck pain for a couple weeks and they do some physical therapy and it gets better. And others have chronic neck pain and have been dealing with it for years. And, so a lot of times the cause of the neck pain is kind of what drives the chronicity or what makes it eventually become chronic. And neck pain, it can originate from muscular pain, can be from herniated discs in your neck, as well as nerve irritation, or even sometimes the vertebrae can cause pain. The vertebrae or the bones in your neck actually have innervation in them. So if people have a trauma and they have a fracture in part of their vertebrae, they can develop neck pain as a result of that. Next slide, please. So common causes of neck pain, I think probably the most common thing that I see in my clinic is just from muscle strain. So, as people age, they tend to, there's a variety of factors, but a lot of it is the muscular support for your spine. So one of the things that we recommend when people have, either neck or back pain is that they work on strengthening the muscles in both their neck or in their back, particularly their lower back. And that helps with posture. Posture is one, part of posture is there is some voluntary component to posture, meaning that there are some things that you can do actively to make sure that, you're sitting up straight with your head, chin level to the floor. But a lot of times people with posture issues, they have some deconditioning in their neck muscles or their back muscles. And that just happens normally as people age, as they start to hit 40, 50 years old. The muscles in your neck, unless you're actively using them, can start to weaken. And what that can cause is people to start to lean their head forward. And there's, being on a computer for a long period of time, or, a lot of cell phone use if you're sitting hunched over quite a bit, can kind of train your muscles to, not allow you to have the proper posture. Sometimes there's overuse injuries, so people who are sometimes people who are too active and exercise too much, and they can potentially have muscle strain in their neck from overuse. Some other causes of neck pain include cervical disc degeneration. So your cervical spine is made up of both bones, vertebral bodies, and then between the bones there are discs, and the discs are the basically joint spaces between the bones in your spine. And what the discs allow is for flexibility in your spine, which is very important in terms of having balance, and being able to move and adapt to your environment around you. So when you're up walking around and you misstep, you can bend and rebalance your weight quickly so that you don't have a fall. And those discs over time, like I said, those are joint spaces between the bones, and those can start to degenerate over time. And that's just from, as people age. Everyone over the age of 40 has some degree of either cervical or lumbar disc degeneration, but that doesn't mean that you're symptomatic from it. And what I mean by degeneration is that the discs between the bones start to wear out, and I'll show you some pictures of that as well. But that's a very common cause of neck pain, and that can also cause arm pain or arm numbness as well. Other causes of neck pain, obviously trauma. Like I said, if you have a fracture in one of the vertebral bodies in your neck, your vertebral bodies have a lot of nerves in them, so that can cause pain as well. Conditions such as osteoarthritis and rheumatoid arthritis, psoriatic arthritis, all sorts of different types of arthritis can cause neck pain and cause disability. Again, nerve compression. So anytime there's any compression on any nerve, that kind of fits in with the cervical disc degeneration. As the discs wear down, you've probably all heard of herniated discs, and the discs, when they herniate or bulge, can put pressure on individual nerves, and that can cause symptoms including both neck pain and arm pain. And then cervical spinal stenosis, that's just a general term, meaning that the canal where your spinal cord resides, where your spinal cord is narrowed. And that's from a combination of factors. That can be from problems with the vertebral bodies, it can be problems with the discs, it can be problems with some of the joints, called facet joints, which are in the back of the neck. All of those factors can contribute to cervical spinal stenosis. And the symptoms of having neck pain or spinal stenosis can manifest themselves in different ways. Next slide, please. So again, these are just an illustration, some common causes of neck pain. Probably one of the most common is muscle strain. So, most people that come into my clinic have some degree of muscle strain, and that's just from either overuse or posture related. A lot of times muscle strain will get better with just physical therapy alone. The pain management doctors as well have some options to treat muscle-related strain and pain. But the good news about muscle strain is that typically tends to get better over time with exercise and physical therapy. Age-related wear, that fits in with osteoarthritis. So again, everybody over the age of 40, 50 has some degree of both degenerative disc disease as well as arthritis as well. But again, who becomes symptomatic from that? It's very variable, and you can look at 2 different CAT scans or 2 different MRIs from different patients, and being able to predict which one is going to be symptomatic can be very challenging, because it's not all, a lot of times it's not cut and dry, and there's a lot of external factors that come into whether or not somebody's going to be symptomatic from it. Bone spurs, that fits in again with osteoarthritis. So as people age, they can develop bone remodeling. So your bone is constantly breaking down and building back up. It's a constant process. And as people age, as that bone starts to break down and build back up, the bone can become remodeled, and that actually can become problematic. Because if you develop these spurs, they're basically abnormal kind of growths within the bone. They can push on either the spinal cord or the associated nerve roots. Nerve compression. This is showing a picture of a nerve root being compressed. The red is the nerve root, and then the blue is a small disc fragment that's pushing on the nerve. So again, we talked about people who have herniated discs, or sometimes we call them extruded discs. You may see that on MRI reports or CT scans. But basically, it's just the degree of how much of a disc bulge that you have. So here, that actually looks like a extruded disc, and sometimes the disc can push on the nerve, and that can cause symptoms of nerve pain and nerve irritation. And typically, when we see that in the cervical spine, we see that as either shoulder or arm pain. Sometimes it can present as numbness. Sometimes it can present as tingling sensation, or we call that paresthesias. Again, injuries from accidents. We talk about people who are in motor vehicle accidents. If you're in a high-speed collision, or even if it's not that high, if you have some degree of whiplash, so that hyperflexion and extension in quick succession can lead to injuries in the cervical spine, which is something that we commonly see at the medical center. And again, there's a whole host of other inflammatory type conditions, rheumatoid arthritis, meningitis, or more rarely cancer. Those are, I would say, among those three, or including things like psoriatic arthritis, are within the minority of patients who come in with neck pain. Again, the most common coming from just age-related wear and tear, bone spurs, degenerated discs, or muscle strain. By far, I'd say 95% of patients, when they come in and see us in clinic, that's what their pain is related to. Next slide, please. So you may have heard of or seen either, on CT scans, if you've ever had a CAT scan of your neck, or if you've ever had an MRI, they may mention cervical stenosis, and stenosis is just a fancy way of saying narrowing. So you can have the two types of stenosis that we talk about in the cervical spine is narrowing within the central canal around where the spinal cord is. So if you have cervical canal stenosis, you have compression of the spinal cord itself. If you have cervical foraminal stenosis, that's narrowing where the nerve roots exit the bony channel into the arm. So the foramen is just another way of saying an opening or exit for the individual nerve roots. So those are the two most common types of stenosis that we see, is central stenosis, central or canal stenosis, and foraminal stenosis, or basically nerve root exit stenosis. And again, by far the most common cause of cervical stenosis, when you have degenerative, or when you have these issues, is they're typically due to degenerative changes, meaning that you have bone spurs, you have bulging discs, or some combination of the two. Next slide, please. So this is an illustration showing the different areas of potential compression. So in the figure on the right-hand side of the screen, you're looking at a top-down view of a cervical vertebrae, and you can see that is there a way I can get a pointer on this actually? Do you know if there's a way I can annotate it, or?
Um, do you have that option on your control whenever you mouse over, you get the control panel? There should be like an annotate, but
Can you
because you
get,
were able to
can you see,
secure,
can you see me drawing there?
yeah, I can. Yeah.
Okay. So this is, this is an illustration of the cervical spine, like I mentioned. It's a top-down view. This area that I circled here, this is what's called the disc space, and the disc is made up of a very firm covering called the annulus. So that surrounds the disc material circumferentially, and within or the center part of the disc is this area. It's called the nucleus pulposus, and that's basically simply it's just soft disc. So when you have a disc herniation or disc extrusion, this disc from the center can herniate and tear through this fibrous capsule here. And when it herniates, it can start to push on critical structures, one being the nerves, which are here. This area from here to here is the foramen. Right here, outlined, is the spinal cord. And again, on the other side, you have the foramen, which is from here to here. This is the front part of the cervical vertebral body. So this is the front, or the part that sits right next to the esophagus and trachea. And this is the back part of the spine here, called the spinous process. And that part attaches to muscles in your neck, and provides, your ability to move your neck and posture. Out here, we have what's called the facets, and these are joints, and they fit together on the levels above and below, kind of like Legos. The vertebral body above and below has very similar joints, and they fit into place with one another. And that also, the facets along with the disc space allow for flexibility in the cervical spine. And again, when we talk about central stenosis is here around the spinal cord. When we talk about foraminal stenosis, we're talking about it out here in the cervical foramen. Next slide, please. So some, again, causes of cervical stenosis. We talked about age-related disc degeneration. We talked about bone spurs, or another fancy word for that is osteophytes. You can have thickened ligaments, which is, as people tend to age, they develop thickened or calcified ligaments. So the ligaments are just areas around the spinal canal. They sit right next to the spinal cord. And over time, if they start to calcify, or become more dense, then they can cause irritation of the spinal cord, or it can cause irritation of the individual nerve roots as well. Again, we talked about herniated discs. And then some people have what we call congenital spinal canal narrowing. Some people are just born with more narrow spinal canal, so they have less ability to tolerate any issues in the cervical spine. So if they develop a small disc herniation, normally, if you have normal anatomy, that may not be symptomatic. But when you have a smaller than normal spinal canal, even a small disc herniation may become incredibly symptomatic. Those are typically the most common causes of cervical stenosis. Next slide, please. So when we're suspecting someone may have cervical stenosis, things that we look for is not just neck pain. So neck pain alone, and I always tell patients, if you have just neck pain or if you have just back pain, surgery, there aren't very many surgeries that treat neck or back pain by itself. Usually what we look for is some other neurologic symptom that you're having, either pain that radiates into your arm, That's called radiculopathy. And that's from nerve root irritation. So these individual nerve roots come off of the spinal canal at different levels. And if you have compression on one of the individual nerve roots, you can develop symptoms that are very specific for that nerve. So typically in the cervical spine, the most common cervical radiculopathies or cervical level or roots that we see are cervical C5, C6, C7, and C8. Typically, kind of the middle of the cervical canal tend to be more symptomatic, and that manifests as pain. You know, typically C5 is in the shoulder, and then 6 and 7 are on the lateral aspect of the arm. C8 is on the pinky side of the hand, and T1 is along the medial side of the arm, just above the wrist. So when I examine somebody in clinic and I say, you know, can you show me exactly where your pain is? And a lot of times people, if they have a problem on their MRI, it fits or it correlates well with where they have the narrowing. I always have some hesitation. If someone has a big disc bulge at one level, at say C4, C5, I would expect that to manifest as shoulder pain because that's where C5 innervates. If they have an issue with one of, say, C7, and you know their pattern of pain is different, then that becomes a little bit more challenging because you know if you're working someone up eventually for surgery, you want to make sure that the symptom fits very well with the MRI, and that'll predict whether or not someone gets better or not. Other symptoms of cervical stenosis, you can have numbness, you can have tingling or weakness in the arms or hands. If you start to develop gait imbalance, meaning that you have difficulty with your balance or decreased dexterity or finger dexterity, if you're having difficulty with buttoning shirts or you're having difficulty opening jars, if you're right-handed and you're having difficulty using your dominant hand or you're becoming weak or having difficulty writing, sometimes that can be symptomatic for what's called myelopathy. And myelopathy is different than radiculopathy. So radiculopathy is irritation of the individual nerves. Myelopathy is irritation of the spinal cord itself. And in that case, typically, patients who have narrowing and they have myelopathy or signs of spinal cord irritation, that's a time when surgery is actually indicated sooner rather than later because when you start to develop symptoms of spinal cord irritation, you can potentially get weaker over time, your balance can get worse, and your ability to regain that function, even with physical therapy, can be more limited depending on the degree of spinal cord irritation. Again, most people who come in and see me, they have a very, you know, if they do have signs of spinal cord irritation, it's very mild. And it's typically not an emergency or urgent type thing that we take care of. But I will say it, you know, doing a surgery for someone who has spinal cord irritation does prevent those symptoms from progressing, from their gait becoming worse or their dexterity from becoming worse. In severe cases of cervical stenosis, you can even have bowel and bladder dysfunction. That's very uncommon. That's usually with you know, people who are very sick from their cervical stenosis or cervical narrowing. Next slide, please. And this is a demonstration here. So this is showing that you know, there are 8 cervical nerves, C1 through 8, and then there's the thoracic one or T1 nerve, which all come off in the cervical spine or just below the cervical spine, which innervate both the muscles and the sensations in the arms. And this is just a distribution of, on the right, the different, we call them dermatomes. This is the sensory pattern. So if you have a disc at C4-5, you would expect potential compression on the C5 nerve root. and I would expect numbness in this area here. So typically on the shoulder. C6 is typically the lateral arm into the thumb, and then actually C7 is just the middle finger and part of the hand. C8 is typically here, and then T1 is on the medial aspect of the arm. So again, this is just an illustration showing that, when we're looking at somebody with a herniated cervical disc, and their exam is different from what we would expect based on this image, then we have a little hesitation. We say, hey, maybe something else is going on, because it's not always a cause from the cervical spine. The cervical spine causes a fair majority of issues, but sometimes there are peripheral nerve conditions, which are more rare but can happen, and we want to make sure that if your exam doesn't make, your physical exam or what you're complaining of, if it doesn't make sense with the MRI, then typically we can do other studies like nerve conduction studies or EMGs to make sure, we're not missing something else. But again, this is just showing the disc between the vertebral bodies. We have the foramen, which is in this area, and you can actually see part of this disc material in the middle. The nucleus pulposus is actually herniating out through the edge of the disc, and it's pushing on the nerve root. And again, depending on what level that's herniating at, will cause different symptoms in both, different sensory distribution, as well as you may have different muscles that are weak based on which nerve is being pinched. Next slide, please. So, in terms of diagnosing cervical stenosis or any issues with a patient's neck pain, we always ask for a full history, and we get a physical exam as well. So we test your strength, we test your sensation, we test the reflexes as well, and all of those help compile one picture in terms of what's going on. We obviously get imaging as well, and between the imaging, the history, and the physical exam, most of the time, say 90+% of the time, we can figure out pretty clearly what a patient's symptomatic from. Like I said, there are some other conditions, the other 10% that are not as clear cut, that we may have to do additional workup in addition to this imaging. But most of the time between these three things, we can kind of figure out pretty quickly what's going on with a patient, and what sort of treatment they may need next. Next slide, please. So here, some of you may have had CT scans of your neck before, or MRIs. So here's this is a cervical spine CT scan here, and we have the MRI on the right. You can see these are the vertebral bodies here. So these white areas, the square, these are vertebral bodies. Between the vertebral bodies, these are the disc spaces here, these rectangles. In the back of the neck, again, we said we had the spinous processes, and these are the areas that attach to the muscles in your neck and help with mobility and moving your neck and turning your neck. There are different conditions. We talked about calcification of some of the ligaments as people age, and basically that can happen for a variety of reasons, but it is common as people age. They can develop calcified ligaments or hardened ligaments, and you can see this is actually patient's ligament here. Same thing here. This is ligament that now it looks like bone. You can see how white this bone is here, and you can see this area right here is abnormal. This area right here is abnormal, and those are abnormally hardened ligaments. And you can see this is this area right here in black. This is the spinal canal, and that's where the cervical spine sits. If you have these osteophytes or thickened ligaments, you can have compression on the spinal canal. So you can see on the MRI on the right, this is the spinal cord right here. And you can see as we get to this level right here, it's very tight. Down here, it looks more normal. You can see this white area behind the spinal cord. This is called cerebral spinal fluid. And you can see a little bit on the in front of the spinal cord as well. At this tight level here, you can see that the cord is actually being compressed. So that can cause issues of spinal cord irritation like we talked about, or myelopathy, another fancy way of saying spinal cord irritation. But you can develop things like difficulty with walking or your balance and decreased dexterity in your hands. Next slide, please. So non-surgical treatment. So, typically tell patients activity modification. So sometimes, for people who just have neck pain, we say, did you change your mattress recently? Did you change, are you using new pillows? And a lot of times, when people say the expression, I think I slept on, I think I slept on my neck funny. I think a lot of times you do strain your neck, your muscles in your neck if you're not getting proper support. And I wouldn't recommend any specific pillow or mattress or anything for any individual patient. I do tell patients they just need to find something that they're comfortable on and they feel like they have good neck support when they're sleeping. And they can sleep most nights without being in discomfort or waking up with a lot of neck pain. Again, under activity modification, working on posture. And again, the best way to work on posture is working on neck strengthening activities, which the physical therapists are excellent at teaching patients, and that helps build muscles in your neck so that you can hold your head straight upright with your eyes level in front of you and your chin parallel to the floor. Physical therapy, they're excellent. We use them a lot both before surgery. We use them a lot after surgery. They are probably more important to a patient's recovery than the actual surgery is itself. I mean, we've seen a lot of patients make remarkable recoveries with different levels of injuries, and a lot of that's attributed to the physical therapists. Medications can help with neck pain. So NSAIDs, like things like Advil or naproxen, if it's more muscular pain or arthritis pain. Medications like Lyrica or gabapentin are good for patients that have nerve pain, so pain that shoots into your arm or in your hands. These medications help modulate or regulate how the nerves are firing, so they can help relieve some pain. Things like muscle relaxants are good short term for muscle-related pain. There are different types of injections, and this comes in with the pain management doctors. So a lot of patients are referred to pain management for different types of injections. Epidural steroid injections, they are, it's a steroid medication, usually with some numbing medication that they put in the epidural space around the nerve. So they don't inject it into the nerves or into the spinal canal. They inject it in and around multiple cervical nerves, and that helps with the irritation of the nerves, and a lot of times can help arm and neck pain. There are things like trigger point injections. There are specific points in your neck where you can get different types of injections, which can help alleviate pain. And then facet blocks. These are the joints between the vertebral bodies, and that can help with neck pain related to arthritis. And typically, these injections can be done every couple months. Depending on the type of injection, they can be done sooner. But a lot of times, if these injections work and they can prevent someone from having a surgery, we always recommend patients do that rather than have an invasive surgery. Even if you need to get these every couple months for a couple years until things get better, most people prefer that, and I prefer that for my patients as well. Next slide, please. Just briefly on the surgical treatment for cervical stenosis, things that are reasons why we would do surgery are progressive neurologic deficits. So if someone's developing worsening weakness, if they're developing worsening balance, if they're developing loss of function in their hands, things that are progressive in nature, a lot of times that's a pretty clear-cut reason to say, hey, you probably need surgery. People with severe pain that's not controlled with pain management or physical therapy. So usually almost every patient goes to physical therapy and sees a pain management specialist before we would consider doing surgery. But sometimes those measures, you do 6 weeks of physical therapy, you work on your posture, neck strengthening, and you're still having pain. I'm not going to go over the surgeries in detail, but just different types of procedures that we do for cervical stenosis and anterior cervical discectomy and fusion, where we approach the spine through the front of the neck and we take out the disc from an anterior approach or through the front of the neck. The last 3 operations, the laminectomy fusion, laminoplasty, and cervical foraminotomy, are just different ways to decompress both the spinal cord and the individual spine nerves. And the goal is to, decompress where the issue is and stabilize the spine as well. Next slide, please. And here's just an illustration of a few of these procedures on an X-ray. Here we have on the left, this is what an ACDF looks like here. So this is a 4-level ACDF, basically where we go in and we replace the disc spaces with titanium spacers filled with bone graft, and it helps fuse the spine across the segment. And what that does is by cleaning out the disc, you take compression off the nerve root in the back, and you fuse across those segments, because sometimes with just normal neck motion, you can have some irritation of spinal nerves if you have compression on the nerves. And typically for this procedure, we put a plate on the front of the vertebral bodies or the bones at the end of the procedure just to hold everything in place. This patient actually had an anterior cervical discectomy and fusion, that's in the front, and then we have a posterior cervical decompression and fusion. We call it a laminectomy and fusion in the back. So we basically put screws on each side into the bones, and we put a connecting rod, and then we put bone graft material in the joints in the back here. And what that does, it serves a similar function where we're able to open up the spinal canal by drilling off a trough in the back. And we're also able to stabilize or fuse the patient with the rods and screws. The rods and screws hold the neck in place until the fusion occurs, where the bone actually grows and connects these levels that are connected with screws. Another procedure that we do is called the laminoplasty. And if you imagine that the spinal canal is a circle, all this is making the circumference of the circle bigger. And this is looking at the back of a patient's spine here, and you have the spinous processes here. These are called the lamina. It's basically just the bone that covers the back of the spinal canal. Out here are the joints between the vertebral bodies. And you can see that we drilled troughs. This is a trough out here, and this is a trough right here. And we use plates to basically create a door for the spinal column. So you're taking a circle and you're turning it into a bigger circle. And what that allows is it keeps some of the structural integrity and muscle attachments on these bones to keep, to help with both the muscle function in your neck and posture as well. And there's different indications for doing each. I'm not going I'm not going to spend any time really going into, the decision making for surgery, but those are just some of the procedures that we can offer for patients if they do develop progressive neurologic symptoms. Next slide, please. And then rehab and recovery. So, after surgery, we always send, even if someone is doing very well after surgery, I always get at least some physical therapy in the hospital where they'll have you get up, walk around, do some light walking. And then we do gradual return to activities, typically about 4 to 6 weeks after surgery. You can start to ease back into normal activities, usually for a fusion, at least 6 weeks, I'd say. And then at 3 months, there's really, as long as the fusion is taking place, we don't really have any restrictions after that. And things that we can do, after the surgery, and this fits in with before the surgery, but important things, we have patients focus on posture, and that fits closely with both core, so your abdominal core, and your neck strengthening activities. Ergonomics, so making sure that you're not hunched over too much while you're working or walking. All of those are important for making sure that if you have a surgery that you continue to do well after the surgery as well. There are some long-term lifestyle modifications, so things that can affect bone healing or can contribute to problems in the cervical spine. Smoking can cause decreased bone density. Things like weight loss can actually help increase bone density and help take some of basically the load off of your spine, both in the cervical spine as well as the lower spine. Diet, so making sure you're taking enough vitamin D, calcium supplements, and then as people get older, and women as they hit the age of 60, at 60, 65 should start having bone density checked regularly with their primary care doctors, unless they have a history of fractures, which are abnormal, and they may want to start getting bone density scans before then. Because there are medications now that they can use to treat bone density and help build up bone density, because sometimes this degeneration is just from having low bone density or softer bone. And these factors can all contribute and can all, add up to causing bigger problems. So we always tell people, try to stop smoking, work on weight loss, try and eat a healthy, balanced diet, and make sure you're getting your bone density checked. Next slide, please. So key takeaway point. So neck pain it's common, and there's a whole host of factors which contribute to it. Cervical stenosis, one of the causes of neck pain, has many causes to it. And our diagnosis relies heavily on both our evaluation of the patient, so history, physical, as well as the imaging. And the treatment ranges from conservative therapy, and we typically start with that. So medications like we talked about, physical therapy, and different types of injections. And then, if patients aren't showing improvement or they're getting worse, then we can consider surgical options. But I would say overall the prognosis is very favorable, as long as, if you're evaluated for these symptoms and you have the appropriate workup, you have the appropriate conservative management. People tend to do well with these problems, even if, they're having a lot of pain, either in the neck or the arm. People tend to do well overall long term with these issues. Next slide. So that's it. That's kind of a quick summary of neck pain and causes of neck pain, as well as radiculopathy or nerve pain. So, if any of you guys have any questions, feel free to leave them in the chat, but I'd be happy to take any questions now.
Yeah, so we did have a few questions. The first one is, I had a laminotomy just under 4 weeks ago between L4 and L5. I'm looking for a new surgeon other than the one who performed my first surgery to perform the L3 to 5 fusion needed in 3 months after my bones get stronger. Is this something you could help with?
So what I'd tell patients, I usually, if someone has operated on a patient, I usually, I wouldn't say discourage, but I try and keep them with their same surgeon for at least 6 months, just for the follow-up period, follow-up evaluation. Um, only because a lot of times you know, that follow-up period is important. And I would say that from a lot of, if you have lumbar or lower back stenosis or issues, a lot of times some of those symptoms may take time to get better. So I will say, managing expectations with patients, I always tell people, you may not wake up from the surgery perfect. You may not be 100%. A lot of times people get better over time, and sometimes that process takes 6 months to a year. So sometimes I'll even tell patients, depending on the procedure that needs to be done and the urgency, I will say give it 6 months, a year. I don't like doing surgeries in quick succession to each other, because if you're having an issue at one level, say at a prior surgery site, or you're having symptoms from that, and then you do a surgery on another level, and then you develop symptoms again, it can be kind of challenging to figure out what's going on. And again, a lot of the natural history of both neck and arm pain, so neck, arm, and back pain, is that it tends to get better on its own. And I will say, to a greater degree, probably in the lower back, people tend to do better with conservative therapy in the lower spine. Even with some pretty, significant, I've had some patients come in with some pretty severe looking MRIs, and they come back in 6 weeks after doing conservative therapy, and they look 100% better. So I would say, I would urge you to stay with your surgeon for some time and just see how your symptoms go. But in the future, happy to see you eventually. But I would say typically about at least 6 months, and a lot of times I'll say, depending on the problem, even a year with the same surgeon.
Great. Next question, can yoga be a cause of neck or arm pain? Do you think it helps or hurts?
I think it helps. I think yoga is great. I think things like Pilates, yoga, any, strength and conditioning things, being in swimming is very good. Cycling is very good. I'd say the more activity, the better. I mean, obviously you can have overuse or muscle strain injuries from, doing too much. But I will say yoga focuses a lot on core strength and balance, and those things are very important as people age. Obviously, if you're, I can't speak for every particular subtype of yoga, but I will say that people who have taken up yoga and who do it correctly with a good instructor, I think it's an excellent resource. And yeah, I mean, I think people do phenomenal with it long term. And again, like I said, if you're doing something particular in yoga, not to say that you can't have like a muscle strain or something, or an injury. I mean, it is a physical activity, but I will say overall it helps.
Great. Next question. Do you have any comments or suggestions when there is a strong possibility that the discomfort is a consequence of severe spasticity?
Yeah, if spasticity is a very broad term, and there is a whole host of conditions related to spasticity. But if you're talking about just muscle spasms itself, not related to any type of congenital condition, or there's things like torticollis, where you basically have abnormal spasticity in one side of the neck. A lot of times those just muscle spasms will get better with physical therapy. I don't recommend taking muscle relaxants long term. One, for there is some element of dependency to it, but it's also just doesn't really treat the root cause of what's causing muscle spasms. A lot of times I'll send those patients, if they're having spasms in their neck, I'll typically send them to like a pain management doctor, sometimes even neurologists can do some types of injections, Botox injections, or trigger point injections like we talked about. And those different types of injections can help with muscle type spasms.
Perfect. And last question, is your only location in the medical center?
I operate out of I'm at Southeast primarily, and I take some call at the medical center as well. So Memorial Hermann Southeast that's where I actually have my clinic.
Perfect. Those were all of the questions, but if anybody else has any questions, you'll see the contact information on the screen.
Great. I want to say thank you. Thank you so much for a great presentation. Personally, I related to everything. So I'm going to watch the video again and again, but I thought it was fabulous. And I know that the attendees were very fortunate to have this information. And again, a big thank you to UTHealth Houston Neurosciences for sponsoring and supporting healthy aging as we move along. So thank you so much to everybody. You will receive the recording probably tomorrow, actually. So thank you again, and everybody stay safe and have a great rest of the day. Bye-bye now.
Okay. Thank you guys. Take care.
Bye-bye.